those areas of the world which are still using fluconazole monotherapy, it's between 50 and 60%. And there are a large number of countries in Africa that are still using fluconazole monotherapy, and in those areas, amphotericin B is not a registered medication. So we are struggling for registration for Flucitazine, and there are some parts of Africa where amphotericin B is still not registered. Cryptococcal meningitis causes about 15% of AIDS-related deaths. And so it's certainly something that we need to improve our treatment of. So the HIV Clinician Society a couple of years ago updated the cryptococcal guidelines, and the basis for that update was really a trial called the ACTA trial, the Advancing Cryptococcal Meningitis Treatment for Africa trial, which was an open-label phase 3 randomized non-inferiority multi-center trial, and it looked at 5 treatment arms. And by the time the South African Clinician Society had looked at updating their guidelines, the 6 and 10 week results were available, and since then the ACTA trial has released a brief communication in 2020 which reported on the 1-year mortality outcomes, and they had 5 treatment arms in the trial. And you can see them listed below. They were a fully oral option, which was 2 weeks of flucytosine and fluconazole, 1 week of amphotericin B and fluconazole, 1 week of amphotericin B and 5-flucytosine, 2 weeks of amphotericin B and fluconazole, and 2 weeks of amphotericin B and flucytosine. And at that stage, before the update, our recommended treatment, our recommended guideline was 2 weeks of amphotericin B and fluconazole. And the 1 week amphotericin B and flucytosine option was shown to be non-inferior, and the 1-year mortality predictors were that the probability of death from the 1 week of amphotericin B and 5-flucytosine was 27.5%. You can see that a week of amphotericin B and fluconazole really doesn't do very well at all. The difference was in fact non-significant, but when you look at the numbers, you kind of get the feeling that that amphotericin B and flucytosine is certainly the way to go, but technically it turned out to be non-significant, but certainly non-inferior. And there are some graphs just to show you. So this so B is the 10-week data, and C is the 1-year data, and you can see that the graphs are maintained from the early report until the 1-year report. There's just a little bit of a switch around between the 2-week amphotericin flucytosine and amphotericin fluconazole outcome, but you can see that certainly the amphotericin B and flucytosine at 1 week was associated with improved outcomes. So obviously, the trial says you give amphotericin B and flucytosine. What's the issue? Why are we even talking about it? And so the issue is obviously that flucytosine is not really available. And those of us who work in central sites have been lucky enough to have access to flucytosine over the last couple of years, but certainly the vast majority of the country does not, and certainly the vast majority of the continent does not. So this is a document that's been produced by MSF, and it shows the map of Africa, obviously, with different colors showing access to flucytosine. And we fall into the pale green area, which is some national program usage with up to 35% of patients having access. And I would venture to suggest that certainly 35% of patients do not have access to flucytosine. So at our hospital, we're a tertiary center in the middle of Johannesburg. We do outreach to 2 secondary hospitals, and that's Bertha Kloa in Germiston and Edenvale Hospital. And those 2 hospitals, which are closely associated with our hospital, do not have access to flucytosine. So they're still giving amphotericin B and fluconazole. So yes, there are some central sites that do have access to flucytosine through donor programs, which have been quite successful for those who have had access to it. But there's there are a lot of people who require flucytosine who are not receiving it. So what about whether it's affordable? So treating cryptococcal meningitis is not cheap anyway, but it could probably be cheaper. So shortening the duration of therapy and the admission to a hospital is likely to have some impact. So this is a graph from a local study that was done. They used the treatment cost of flucitazine for a 50 kilogram person per day, and they decided that that would cost $9.38. And you can see that for each patient to receive a week of amphotericin B and 5-flucitazine, it's going to cost $2,698. To receive 2 weeks of amphotericin B and flucitazine, it's just going to be very, very slightly more than that. A week of amphotericin B and fluconazole is the cheapest option, but we know that that has very, very poor outcomes, so that's not really an option. And 2 weeks of amphotericin B and fluconazole is a little bit cheaper. It sort of falls between those two options, and then the oral option for patients who are not going to be able to receive amphotericin B also falls between those two options. This again is from the document compiled by MSF, looking at costs in South Africa. Again, this is a slightly different. It looks at costs per 1,000 patients for a 2-week induction phase. So that would be amphotericin B and fluconazole induction, and that would cost just over $2 million. Whereas for amphotericin B and 5-flucitazine, that's pretty much half. So despite the costs, flucitazine seems to be more expensive than fluconazole. Despite the costs of the drug itself, if you factor a number of different things in, so your hospital basic costs, the cost of medical staff to look after those patients in hospital, the number of tests that you're going to be doing over a 2-week period compared to over a 1-week period, including obviously the medication costs. And so it looks really like giving amphotericin B and 5-flucitazine is a very effective option from a cost-benefits point of view. Interestingly enough, looking at liposomal amphotericin, which is the third bar down, it's not substantially more expensive than using amphotericin deoxycholate. So one hopes that eventually we, in addition to having access to flucitazine, will have access to liposomal amphotericin. So what is flucitazine? So flucitazine is a fluorinated cytosine analog with antifungal activity. It's an old drug. It was first developed in 1957, so it's 64 years old this year. By itself, it has no, given as is, it has no antifungal activity. It has to be metabolized first. It's deaminated to 5-fluorouracil, and 5-fluorouracil is substituted for uracil in RNA synthesis. Also, a downstream metabolite, fluorodeoxyuracilic acid monophosphate, inhibits thymidylate synthase, and that interrupts nucleotide metabolism and DNA synthesis. And ultimately, if you interrupt RNA synthesis and you interrupt DNA synthesis, the organism can't make protein. And I put a nice picture of a molecule in the corner there. And since I'm sure most of us are not familiar with molecules, that's actually a molecule of chocolate. All right, so it's active against yeasts, it's active against Candida species and against Cryptococcus, against some of the fungi causing chromomycosis and Aspergillus species as well. It is possible that some fungi may have intrinsic resistance to flucitazine, and if you give flucitazine by itself, you are likely to end up with resistance. So monotherapy is associated with the development of resistance, and it's not advised. There is some interaction with amphotericin B. There's postulated synergy between the two drugs, although that's it's not guaranteed. It's not something that everybody believes. And there may be decreased elimination of flucitazine when given with amphotericin B related to its renal metabolism. So it is rapidly absorbed orally with high bioavailability, which is why it can be given as a tablet. There is an IV formulation, but we have the oral formulation available. The peak concentration occurs after 1 to 2 hours. So if you are performing therapeutic drug monitoring, which is what a lot of international guidelines recommend, our guidelines do not, but many international guidelines will recommend it. You sample at 2 hours after the oral dose for the peak level, and the peak level that you're looking for is between 25 and 100 milligrams per liter. And what you're looking for is you're looking for essentially toxic levels. So you don't want the level to be above 100 milligrams per liter. It is highly water soluble, it is not protein bound, and it is eliminated almost essentially by glomerular filtration in the kidney. So our new guidelines from 2019, not that new anymore, although it feels like we've done, so much time has passed so quickly in the last 18 months that they feel new still. The new guidelines recommend a reflex CRAG screening at CD4 counts of less than 200 and an LP for all patients who have a new CRAG positive test. And then in terms of treatment, so amphotericin B at 1 milligram per kilogram per day, in addition to flucitazine at 100 milligrams per kilogram per day in 4 divided doses over a week, and then a 1 week of high-dose fluconazole, and that constitutes the induction phase, and then you will move to fluconazole maintenance therapy. Or the alternatives are, so the amphotericin B and flucitazine is the recommended treatment. There are alternatives that you can consider if flucitazine is not available, or amphotericin is not available, or you can't give it for some reason. So amphotericin B deoxycholate and fluconazole at 1,200 milligrams a day for 2 weeks, or flucitazine and fluconazole for 2 weeks. This is a nice little cheat sheet in terms of how many tablets that actually is. So the flucitazine comes in a 500 milligram tablet, and it's 100 milligrams a day or 25 milligrams per kilogram every 6 hours. And obviously it's, you're going to get numbers that don't quite add up to 500 milligrams, but you need to give the 500 milligrams in a dose as close as possible, obviously. And this is a useful cheat sheet for figuring out how many tablets you need to be giving your patient. So what to do in renal dysfunction? So if we're giving amphotericin B, we are always concerned about renal dysfunction. Even liposomal amphotericin B is not associated with a zero risk of the development of renal dysfunction, and obviously it's more likely to occur with amphotericin deoxycholate. So if your creatinine clearance is less than 50, your first prize is liposomal amphotericin if you have it available. And every now and again, we have some liposomal amphotericin B. Certainly, we have more patients who would benefit from it than we have access to it. But liposomal amphotericin B, and to remember that the dose for liposomal amphotericin B is higher than for deoxycholate. And then you give flucitazine dose adjusted for creatinine clearance, and followed by a week of fluconazole, again, dose adjusted for creatinine clearance. The second prize is if you have to give deoxycholate, you give the same dose, 1 milligram per kilogram per day, with flucitazine and a week of fluconazole. It is only a week of therapy, so you hopefully will be stopping your amphotericin B after a week, and if you manage specifically the fluids with great attention, you can probably get through that week of giving the patient amphotericin B deoxycholate without significant worsening of the renal function. So if your renal function is significantly worse, if your creatinine clearance is less than 30, then the first prize again is liposomal amphotericin at the same dose, and the flucitazine and fluconazole dose adjusted according to creatinine clearance. Your second prize then is the fully oral option, which is flucitazine and fluconazole, both of them dose adjusted for 2 weeks. And then the third option, which is much more labor intensive, so you would give 0.7 milligrams per kilogram as a single daily dose, and then you would give it every other day if the creatinine remains stable. So obviously that requires a lot of monitoring, and obviously then you will give the fluconazole dose adjusted for creatinine clearance, and you would give that for 2 weeks. So that's not an ideal option, and we know that the outcomes for cryptococcal meningitis are poor anyway. So we would want to see, if possible, to use either the fully oral dose or the liposomal amphotericin B. So this is how you dose adjust. So this is from Sanford, the Sanford guide. This is published in the South African guidelines, and it gives you an idea of how to dose adjust fluconazole and flucytazine. This guide suggests that even if your GFR is less than 10, you don't need to reduce the dose. Obviously, every case is individual, and there may be other factors that will impact on your decision as to whether or not to continue with a 1 milligram per kilogram or to reduce the dose to 0.7 milligrams per kilogram. Also just to mention, if the patient is on dialysis, that fluconazole and flucytazine do need to be dosed after dialysis, so they are not removed by renal dialysis. So what about flucytazine toxicity? So flucytazine is generally mild. The toxicity is generally mild. We don't really have patients complaining too much about the gastrointestinal effects. Certainly nausea and vomiting are associated and have been described. One of the suggestions in terms of managing those gastrointestinal side effects is to split the dose. So if you're taking 4 tablets or 3 tablets, you can split the tablets up over about, so every 15 minutes or every 20 minutes you take a tablet, and that seems to be reasonably effective at reducing the side effects. GI inflammation and ulceration has been described, so colitis and perforation have been described, but it's extremely rare. It is associated with increased liver enzymes and possibly jaundice, and again, hepatic necrosis cases have been described, but it's extremely rare. One of the other concerns is certainly cytopenias, and you will see that a full blood count is recommended as part of the dosing schedule, part of the laboratory monitoring schedule. But the cytopenias generally are likely to occur at high drug levels, so drug levels outside of the therapeutic range, above 100 milligrams per liter, and when given for long periods of time. So for the week that you're giving the flucytazine, even if you're not doing any therapeutic drug monitoring and you're not sure what the levels are, it's a short enough period of time that those cytopenias are unlikely to occur. From an anecdotal point of view, we don't use flucytazine for many other things, but we did have a patient recently who was receiving flucytazine for a long period of time for Candida auris infection, and he certainly developed cytopenias, which we believed at the time were related to the flucytazine. So how do you manage the cytopenias? So you just need to make sure that your dose is correct. So if your patient does have some degree of renal impairment, you need to make sure that you are dose adjusting correctly. Always worthwhile considering alternatives to flucytazine as a cause of the neutropenia. If there is a severe neutropenia, so that's less than 400 or 500 cells, then you would reduce the dose of the flucytazine. You would repeat the neutrophil count immediately, if that is an option for you where you work. And if you have confirmed the neutropenia, then you withhold the flucytazine until the counts recover, and you substitute the fluconazole for flucytazine. It may be that by the time the counts recover and you have an option to reintroduce the flucytazine, you feel like the patient has received a sufficient dose of amphotericin B and fluconazole to constitute an induction phase. But always bearing in mind that the flucytazine and amphotericin is a better option in terms of long-term outcomes. All right, so this is my last slide in terms of safety. So flucytazine in pregnancy. So our current guidelines are going to recommend that standard therapy for treatment of HIV-infected pregnant women with cryptococcal meningitis. However, flucytazine is a category C drug for pregnancy. And so the recommendation would always be to balance the the risks against the benefits. And I think if we consider the mortality associated with cryptococcal meningitis, especially with substandard therapy, if we are considering that the standard of therapy includes flucitazine, one must remember that the mortality is very high, the short-term mortality is high, and the long-term mortality associated with cryptococcal meningitis is high. The flucitazine is associated with teratogenic changes, but one must also remember that a mother who dies from cryptococcal meningitis, the fetus is going to die as well. And a mother who dies at a year or at 6 months or at 4 months following substandard treatment for cryptococcal meningitis may leave an orphan child behind. So one needs to balance the very high risk of mortality and morbidity associated with cryptococcal meningitis against the benefit of providing the best standard of care. So our current guidelines recommend that if an HIV-infected pregnant woman presents with cryptococcal meningitis, they receive standard of care, including flucitazine. And that's all I have to say.
Thank you very much, Stacey, for enlightening us around the use of 5-flucytosine in cryptococcal meningitis. I mean, clearly this is a disease with a very high mortality, and we should do everything we can to reduce that mortality. And clearly 5-flucytosine is an important drug. I've been waiting for questions to come through on the chat, and while people are formulating their thoughts, I was just wondering, from your experience, how much of toxicity have you seen that could be attributed to 5-flucytosine?
So I must be honest, with the short duration that we use it for, we don't really see significant toxicity. I mean, I think we still see more toxicity from the amphotericin B that we're giving than we do from the flucitazine. The one case where we used it for an extended period of time, we think that it did induce some bone marrow suppression. But for the week that we have been, we use it for amphotericin B, we really don't see significant toxicity.
Yeah.
And I think it's a fairly benign drug to be giving for that period of time.
That has been our experience here as well. And by the time you discover the toxicity, the week has passed and you don't need the drug any longer, which is really good. Yeah. I mean, we have used it for a prolonged period in a patient who had recurrent cryptococcal meningitis, and we wanted to sterilize his CSF. But what we've noticed is that it was actually very well tolerated. It was a young chappie, so maybe it was his youth on his side, but we really didn't have any problem. So it's a drug that's easy to administer. One of the challenges we have had using it is the 4 times daily dosing. Have you come across that as a problem with your use of the drug?
Not routinely. I mean, I think intermittently. So we have all our cryptococcal meningitis patients concentrated in one ward, and so the sisters, I think, are used to treating those patients, and I think they've just become used to and aware of the fact that it is a regular dosing schedule. So we have that advantage. But I do think it doesn't really fit in with all the other dosing schedules and the medicine rounds that the sisters have to do. So it is a little bit more complicated.
Yeah.
But I think when people are familiar with it and they're aware of it, it does become a little bit easier.
Yeah. In our case, it has been a challenge simply because we have got cryptococcal meningitis spread across all the medical wards.
Yeah.
And what happens is that the nurses give the patient the medication and says, you need to dose yourself 4 times a day. So good luck with that. And these are not particularly well patients. Every day feels the same, all hours the same. So there have been mess ups along the way. So that has been a real challenge. That's why I'm so pleased that DNDi is looking into a long release formulation. That would make a huge difference. And we're also considering the possibility of using 5-flucytosine as an outpatient, on an outpatient basis in patients that can be released from hospital earlier with fluconazole. And if it's dosed less frequently, then we're more likely to get good adherence.
Yeah.
So Stacey, you've done an excellent job. Everyone seems to be pleased with what you have said. And there are no questions. So we'll move on to the next session, but please stay on.
Eunice, there are 2 questions in the chat that I believe you can't see. So if I can read them to you. Given their importance and clinical benefit for patients at need, having access to Flucitazine, and also despite numerous clinical motivation and follow-up attempts, why is SAHPRA taking so long for its registration? That's the first question. So it is to comment
Stacey.
on SAHPRA's processes.
I think the next session is going to deal with the operational challenges associated with Cytosine. So perhaps that can wait until. I agree with you. It's time already, but
yeah, it's a huge problem, and I think Stacey is correct. We might address that at the next session. So maybe Yogan should take a note of that. Is the other question, Lauren? You mentioned two questions, Lauren.
The second question is also about the next session. Why has the rollout of Flucitazine been so poor in South Africa, and are there issues with the cold chain? And perhaps we can leave that over for the next session.
Yeah, excellent. I think that's a good idea. I'm glad those questions are coming in. It clarifies the need for the next session. So I will introduce you to the next session, and maybe you can start switching screens. Go ahead, Stacey. Okay, all right. Right, so what we've got next is a panel discussion around the challenges experienced in operationalizing access to 5-flucytosine. This session will be moderated by Dr. Yogan Pillay, and I'll just give you a little preamble about Dr. Pillay. He's the director of CHAI in South Africa since June 2020, and he comes with extensive experience working with the Department of Health in South Africa. He was the Deputy Director General for Health Programs for the National Department of Health, and prior to that was the Director for Strategic Planning, and prior to that was the Director for District Health Systems. So I cannot think of anyone who has got a more intimate experience and understanding of the workings of the South African healthcare system. So I think he is the excellent person to chair this, and probably doesn't need the panel around him. He can do it all on his own. Anyway, so what we're going to talk about is Dr. Yogan Pillay is going to do this session. He'll introduce the different panelists, and the discussion will be around how we can get 5-flucytosine accessible to everyone within the healthcare system. Yogan, the mic is yours.
Yes, thank you very much, and good morning to everyone, and welcome to the panelists. So the way we'll run this is that I'll ask each of the panelists to speak on their experiences with using 5FC for about 5 minutes. We should then have about 10 minutes at the end for a more fireside chat kind of discussion. So let me introduce the panelists. I'll introduce everyone up front, and then we will get going. And thanks to Sarah for her overview of the use of the various treatment regimes currently and the clinical guidelines. So I'll introduce them as they would be speaking. And so the first speaker is Dr. John Black. John is an infectious disease physician at Livingston Hospital. He trained at UCT and started working at Livingston in 2014, where he started an ID unit. John is involved in research on MDR TB, TB meningitis, and cryptococcal meningitis. And lately he has devoted time to treating a lot of COVID patients, which I'm sure he will reflect on a little bit as well, John. So that's Dr. John Black. The next panelist will be Dr. Pheto Mangena. Just looking for my notes for Pheto's CV. Pheto's CV is a one-liner that I got at least, and Pheto, you might want to say a bit more when you speak. He's a trained physician and nephrologist. So that's Dr. Mangena. I think everybody knows Eunice, so I don't think there's much I can do to introduce Eunice. He's already introduced himself as an associate professor and chief specialist and head of Department of Infectious Diseases at UKZN, and he's the president of the society. And then finally, we have Jackie Voget from the Western Cape, and Jackie will be speaking about her experiences in introducing 5FC. She's employed as a pharmaceutical policy specialist in the Western Cape Department of Health. She's a registered pharmacist and has completed a master's degree in HIV management, and she supports the provincial health programs by providing clinical and pharmaceutical support. So with those introductions of our panelists, John, in Livingston, you've been using 5FC. What's your experience? Besides your experience, can you tell us what challenges you've experienced and what you think we can do about them, both in the Eastern Cape and more broadly? John, over to you.
Yeah, thanks very much, Yogan. We've been using Flucitazine for probably 5 years now. We started off in a very small way, treating those patients with complicated issues, and we initially applied for it through a Section 21 application. It was approved by our local therapeutics committee, and we got quite a lot of experience there. And then finally we connected with CHI, who then gave us a good supply of the Flucitazine, and it's really revolutionized the treatment of cryptococcal meningitis. We've got a lot of patients, in a resource-poor setting where nursing management is very difficult, your fluid management is difficult. And we certainly, on a review of our cases, probably the first 150 cases showed a reduction in mortality. We also reduction in hospital stay, and the patients just did much better. And I don't think there's any doubt that the use of Flucitazine is really what we need. The issue really is around the access to the Flucitazine. Just, with access through CHI and the access program, the issue about using it and protocols and all of those things are fairly simple. I think the biggest issue is that if you've got a steady supply and that's what you can use, the training and the implementation of protocols are very easy. So to draw up a protocol, the Clinician Society has a lovely document that really outlines how you use it. We certainly had a protocol prior to that, and once it became standard of care in our patients, the uptake was incredibly good. The training was easy, and despite interns and medical officers rotating, it was very, very much just became a standard of care in the hospital, and very low toxicities and just generally better outcomes. The issue really for us was expanding the access, because this is not something that only occurs in tertiary hospitals. A lot of cryptococcal meningitis will occur at the regional hospital, at district hospitals, and our pharmacists were able to liaise with pharmacists in other hospitals. So we were able to expand that access to another number of regional hospitals and district hospitals in the area. And they have started treating cryptococcal meningitis there with Flucitazine. And I think the overall feeling is that people really like the versatility of it. When you've got renal impairment and you've got other issues, that you can have an all-oral regimen where there's amphotericin B toxicity, and it really is the way to go. The concern, obviously, is number one is the equitable access. We obviously want as many people on this drug as possible, and we've certainly managed to now get access in Buffalo City or East London, as well as other areas, but there's still large areas within the Eastern Cape that do not have access. And to procure it outside of an access program is a very costly thing. And I know the EML has reviewed it, and they have accepted it they support the use of it. They've also done some cost-effective analysis, which shows that it's very good. But unfortunately, you can't put it in the EML or a Department of Health guideline as an unregistered product, which means that if they do put it on there, then there's a legislative requirement for them to provide it. So unfortunately, the access to it at this point is through either a Section 21, and I think you'll hear from the Western Cape that they can afford it. But I think the majority of provinces can't afford extensive access to this outside of the access program. So I think we're waiting for SAPA approval, and that really is, once it's registered, we can go through that route. But until it's registered, we're stuck with this sort of in-between area where you're relying on a donation. And to make it more equitable, we need to know that there's sustainability of that donation until registration occurs. And you've got some sort of distribution point or process within the province to be able to accept the donation as well as then distribute it in an equitable way. And then once I think you've got that full, the supply lines are there, then I think the implementation issues are very easy. Guidelines are available, training is easy. But once you've got stock interruptions and stock problems, then people lose faith in that, and there's back and forth between where you've got fluconazole, flucytosine, and then the uptake isn't as good. So I think the key issue is a key pipeline in terms of your stock, and then from there, a good training and implementation process with good evaluation of stock levels and clinical outcomes. So I think I can leave it there and hand it over to Pheto.
Great, thanks, John. Pheto, your experiences in Limpopo? Over.
Okay, good morning to the panel and all the audience. So our experience is maybe the opposite of what John has experienced in the Eastern Cape. So I'm also in a predominantly rural province in Limpopo, and what we've found is we've been had access only in the tertiary hospital for just over 2 years after being invited to take part in the MSF access program. So in the first month or two, there was enthusiasm for using flucytosine because most people understood the literature and could see the benefit of giving it oral as well as the lower side effect profile. But what seemed to hobble widespread use of it was we had an internal protocol which limited its indication to patients who either had pre-existing renal impairment or developed it after starting amphotericin B. Now, the reason our protocol initially specified this was there was uncertainty 2 years ago regarding the amount of stock that we would have access to. And so in a sense, that made people less willing to use flucytosine as the first line of therapy. And then added to that was just lack of knowledge. In the past few days, I've been asking medical officers and consultants within my department what their experience with prescribing it and using it is. And funny enough, one of the first responses I received was from a fellow consultant who says, but do we have flucytosine in this center? So that is a problem because it means even on ward rounds, our consultants are not suggesting that we use the drug. Similarly with pharmacy as well, every time we receive stock in our institution, I get phone calls from pharmacists who don't fully understand why we have access to flucytosine and what the indication is. And one has to start from scratch explaining to a different pharmacist the conditions under which the drug has been received and its indication and the like. So there seems to be a lack of diffusion of knowledge within our center, which is a great concern, which should prompt us to have a better training and awareness program within this facility, but also now that we're looking to expand across the province to encompass other individuals around the province. And then lastly, one of the other surprising responses I received was one doctor told me they were somewhat discouraged by the Section 21 process. They found the form too long, and they related an experience of having the form being returned from pharmacy due to one or other errors in completion. And once again, that just makes people less reluctant to consider it for its use. So on reflection, clearly these are problems that are easily surmountable. And so the way forward really for us is to engage with people a lot more, maybe in the form of lectures, but also to visit people in their wards, join them on their ward rounds, and maybe proactively look for crypto cases and have a little chat with the treating team just to ensure that people understand that the drug is now available in greater quantities, potentially with greater security of supply. And I think the benefits are quite obvious, and I don't think we should have a challenge convincing people of its benefits. Thanks.
Great, thanks. Pheto, does that mean that besides the tertiary facility that you're working in, it's not available anywhere else in Limpopo, right?
Up until now, that's correct. So deliveries were only limited to Petersburg Hospital in Polokwane as the tertiary facility for the province. I will add, however, that once or twice I've received calls from doctors at our feeder hospitals who would have a crisis where they have a patient who might be intolerant to amphotericin B or may have unresolved renal dysfunction, and they are concerned. And at least in those cases, we've been able to courier the drug to those facilities upon receipt of the Section 21. I have been in discussions with the team at CHAI, and since last month, we decided to roll out the program to the remaining regional hospitals within the province. So within a few weeks, we expect at least 6 other hospitals in Limpopo will be able to receive stock and start providing it to their cryptococcal patients.
Great, thanks for the additional information as well, Pheto. Eunice, you already started explaining some of your experiences. Any further experiences from KZN, Yunus?
Yeah, when MSF first approached us, I think this was in 2018. I'm going back way back into the past. And in 2018, with this idea, and it was a very sensible idea that they came with. They said that the pharmaceutical companies are happy to expand the availability of the drug, and they're happy to reduce the price of the drug, but obviously economy of scales is what will drive the price down. So we have to demonstrate that there is a need for the drug and there will be increased use of the drug, and as a result of that, prices will come down. However, they were not prepared to register it until there was increased use of the drug. And the utilization of the drug would not go up until the price comes down. So it was a circular problem. So what CHAI and MSF decided is that they will acquire the drug, create a need for the drug, and then demonstrate to the company that, yes, you can increase your production 10, 20-fold, drive the price down, and now it will then be taken over by the National Department of Health for use of cryptococcal meningitis. And introducing 5-flucytosine into the therapeutic armamentarium was a no-brainer. I mean, it had huge advantages: decreases hospital stay, uncomplicates the treatment, reduce monitoring, getting out of hospital sooner, less toxicity, decreased mortality. So when they came to us with this idea, we were very excited by it because we realized that this was something that we would need to use. But the problem is it came to us in the form of us appealing to the Department of Health to consider allowing us to use the drug at our sites. And we are clinicians working in the coalface. We really don't know the workings of the Department of Health beyond the confines of our hospital. So it was a huge learning experience on who we should go to and what we should give them so that they can consider using the drug. And when I first started, in my mind, this was pretty straightforward. I mean, we're giving somebody something for free, asking them to allow us to use it for free that will save them money. So in my mind, I could not imagine that there would be any reason not to allow it. However, we were surprised because the responses that we got back from the Provincial Department of Health was, are you trying to do research with the drug, and why is this drug not available to all sites equitably? Why are you choosing particular sites to use the drug? And I think they might not have realized that this was sort of a gradual introduction and a controlled introduction so that we can get people accustomed to using the drug, get familiar with using the drug, and then drive the use of the drug initially at few sites and then expand beyond. And then subsequently, so in KwaZulu-Natal, we were actually the last to engage the process. All the other provinces had already started using the drug. And unfortunately, I think it was either MSF or CHAI managed to do two important things: is get the National Department of Health to approve the use of the drug, number one, and to get a national approval from SAHCS to use it as a Section 21 drug, which reduced the amount of work that we had to do in our local sites. Since then, we've re-engaged the Department of Health, and they seem to understand what we have in mind and have given approval to use the drugs at all of these areas. The second problem was convincing people at the various sites to start using the drug. And the problem really wasn't convincing them to use it because of the benefits from the drug, but it was an SOP that applied in some cases and not in others, very similar to what was in Limpopo. So in other words, there were specific indications, and we put down those indications because we were concerned about supply chain. If we had opened it out so that all patients would get 5-flucytosine for cryptococcal meningitis, we might very well run out of drug. So we had to use it in a selective manner. And the problem with using it in a selective manner is that people have short memories, they forget about the drug and they don't use it. So those were the few challenges that we experienced. And then what I've got to realize is that when a drug is first introduced into the market, it's usually done by a pharmaceutical company who's got a vested interest in making a lot of profit out of the drug. So very often, we as clinicians are only engaged as part of CMEs to talk about clinical experience, but all the logistics and the admin and the governance that goes behind making drugs available, convincing departments of health to use the drug, in making sure supply chains are maintained, are all taken care of by the pharmaceutical company. And here, we as clinicians on the ground who have got many other things keeping us busy, needed to get that in order. And that was a huge challenge, finding time, understanding the processes, and trying to do that. It has been difficult, but I think that the benefits to the patient are huge. And I think we are finally reaching a point where we can start using it initially at selected sites, but hopefully expand it beyond. So I'd like to thank CHAI as well as MSF and DNDi for persisting and assisting us in trying to get this through. I'll stop here and take any questions as we come along. Thanks, Yogan.
Great. Thanks very much, Yunus. And clearly, when you have anything that's constrained by supply, you're going to have constrained use as well. So fairly clear. Thanks very much, Yunus. So let's move on to then experiences from the Western Cape, and I'll hand over to Jackie.
Good morning, everyone. I must say our experience was it's not as easy as it seemed. It also took quite a while. We started the process in 2018, and our first stop was at the Provincial Pharmaceutics and Therapeutics Committee. There's also a time delay because they only meet every quarter. But luckily for us, the evidence was sufficient for them to support our submission. And the one condition was that we had to make it available throughout the province so that all patients can benefit from Flucitazine. Our next step was we included costing and some forecasting because we could, from NHLS data, understand what kind of burden we were looking at and how much we would need to procure. After that was getting in touch with the company and getting information for our Section 21 application. And that also took some time. And we decided to do a bulk Section 21 application for the province to lift the burden off the facilities, because as previous speakers mentioned, it's quite tedious to do individual Section 21 applications. Our application was approved within 1 day by SAHCS, so we were very fortunate. But there's other internal supply chain processes that we had to go through. So our stock only arrived in May. So from January, after the Section 21 was approved, our stock only arrived in May, and we only properly kicked off in June. We decided to keep the stock at the depot as a line item so that everyone had access to it and could order it through the normal order procedures in the province. I think there were different areas where we could have improved. For example, training. We included the Cytosine training in our bigger HIV guideline training when dolutegravir was introduced. And in hindsight, clearly we had the wrong audience for the Flucitazine session. And talking to different hospitals, it became apparent that most of the teaching happened around the bedside and doing ward rounds. And that is where people were mostly trained about Flucitazine and the new treatment regimens. But some hospitals did not have ID specialists. Some ward rounds did not include specialists. And a lot of the queries ended up with the hospital pharmacy staff, who then also did not receive proper training. So from our order patterns, we could see like after a year, after 12 months, things settled, which means that is more or less how long it took for for the new guidelines to filter through. So even despite the medicine being coded and it being channeled through all the hospital and district PTCs, all our tools being updated, being updated, it still didn't necessarily reach the people on the ground. And I think this is what led to the slow implementation during the first year. So that is our experience. So we've been seeing a stable demand for it. Luckily for us, we didn't have to venture on a second Section 21 application because we could also join the access program. So we are also very grateful to Chai for that opportunity.
Thanks, Jackie. Jackie, how many patients do you guys have, and what's the forecast like in the Western Cape, so that we have an idea, on what you're looking at?
We're looking at about 500 to 600 patients a year, so that's about 40 a month that we treat, and some small hospitals see 2 or 3 patients a month. So I'm not quite sure how that compares with other provinces, but that's our burden.
Great. And it seems both from Pheto and Jackie, your presentation, that training of clinicians and training of pharmacists are quite critical to the introduction of new regimens, new drugs. And would you recommend a bulk Section 21 to other provinces? And can you say a little bit about how you went about doing it? Because I'm quite surprised that SAHCS took 1 day to give you approval, because that's not most people's experiences, unfortunately, of SAHCS turnaround time. Over to you, Jackie.
That was the first time I did a bulk Section 21 application. It was early in January, so it must have been very quiet. And it was on the new electronic submission system. It became increasingly difficult as the access program started to develop, because I think NDOH wanted one stream of access to Flucitazine. So I think we were fortunate enough to have a successful bulk Section 21 application early in 2019, before the access program started. We've got quite a good structure supporting health programs in the province. It includes ID specialists from the academic institutions, different hospitals, and other clinicians. So I think we had buy-in from the start. Our existing system of provincial memos and circulars, people are used to that kind of way of conveying changes in policies and treatment regimens. So I think we had some kind of a foundation, but as I said, it was also had its faults, that it didn't always filter through, and I think there was major gaps in the training.
Great, thanks. I don't know, Graeme, Meintjes, do you want to come in as a clinician in the Western Cape? Because we've heard from Jackie working at the provincial level. Any views, experiences from you, Graeme?
Yeah, I think the advantage in the Western Cape is it was managed centrally and taken through the directorate, and then the access was done centrally, and with that key underpinning principle that Jackie referred to, that if there was going to be access, it had to be fair and available to all across the province. And then so the access issue was sorted out, and then the circular came out, and clearly, it does take time to translate from a circular to knowledge within the ward context. But, at least that circular is taken up by pharmacists who can then advise clinicians. So I think, as opposed to having piecemeal and limited access, and having, a broad access with a policy framework, certainly, made it easier to implement, and and then as Jackie said, informal networks of clinicians phoning if they were using it for the first time at their hospital, if they had issues, phoning other clinicians that had experience and getting advice, meant that it took a few months to implement. But now I think as John had said, once it's in place and the protocols are there, people are comfortable to use it. It's not particularly complicated.
Great, thanks. We'll go back for last comments from the panelists before we close. So Eunice, can we ask you to make your last comment and also to tell us whether or not you've been educating patients and the HIV community in KZN, Eunice? Over.
Yeah, well, I actually had a question that I wanted to ask. When we were approached by CHAI as well as MSF to try and make this drug available in the province, I was just wondering whether we were the right people to have been approached. Should the pharmaceutical services, this is a drug that needs to be made available. I mean, and clinicians certainly have a role in rolling out the drug, but the primary individual that should have been liaising with the pharmaceutical services within the province and within the authorities that give you authorization to use the drug, would the people engaging them not have been the pharmaceutical people, the pharmacists themselves that are involved? So I just wanted to know whether the experience in Cape Province would help us decide how best we should have done it. That's number one. Number two is that in terms of patient education, we haven't rolled out en masse patient education, but however, we depend on the clinician that is seeing a patient to educate that particular patient about the drugs that are available, the drugs we are planning to use, their toxicities, and the duration of treatment, so that the patient walks out realizing that instead of getting an IV formulation, he's getting an oral formulation and the efficacy of the oral formulation. So we've depended on the clinicians to drive the patient education rather than doing it en masse the way we do for HIV or for tuberculosis. And remember, there's a large number of patients, but a small proportion of HIV positive patients get cryptococcal meningitis. So it makes sense to do it on a one-on-one basis with patients that do have the disease. I'll stop there.
Great. Thanks very much, Yunus. Pheto, any last comments from you?
No, I think overall it's good to hear different people's experiences, and one can contrast John's experience with a clinician-led rollout with the Western Cape's more provincial office-led rollout. And it's interesting that they've both had successes with the different approaches. So I think our rollout will also have to take into account the context of our province and what generally works well for us. And I think we'll learn a lot from Jackie's point that we need to drive teaching from ward rounds, because CMEs are great. People sit, they feel that their heads have been filled with new information, but we also need to engage people at the front line itself, because old habits do die hard. And I think that's been for me, that's been our biggest failure is as much as people used a lot of Flucitazine the first month or two, after a while, for whatever reason, muscle memory went back to prescribing amphotericin B. But overall, we're excited to have access to it, and I think we need to do better in terms of actually using a resource when we have it. And for that reason, we're thankful to CHAI and DNDi for their efforts to improve our patients' outcomes. Thank you.
Great. Thanks, Pheto. Nilesh has just posted that, at least from the lab diagnosis, there are about 100 cases of cryptococcal meningitis per week in South Africa. And if you look at the mortality rate of between 40 and 60%, and according to Nilesh, we only have about 6% of our crypto patients on this regimen. So, we have a long way to go. Let me hand over to John for your comments. John, your last comments. Over.
Thanks, Yogan. So I think just to reflect again, the Western Cape experience, I think is partly, to realize that the provinces all have very different financial capabilities and their fiscus and control of them are very different. And I think you're unlikely to see provinces outside of the Western Cape being able to actually purchase Flucitazine unless it's a lot more affordable as a Section 21, which, and that's in keeping with the national EML legislative issues. I don't think they want to take on that particular financial burden because that's going to create a lot of legal liability and other things. So that means a lot of the pressure has to come on the company to register the product and go through that process So it can then be put on the EML, and then we can access it more broadly. I think the reason that the clinicians are rolling it out in this way is because the provinces and the authorities actually can't commit to purchasing these items. And that means that this access program needs to fill the gap until such time as SAHCS gets you can't force the company to register, but I think the advocacy should be to try and get them to register. And I think SAHCS would then, with all the pressure on them, would look at registering the product in a fairly rapid manner, and then we could take it through from there. So, that would be a way through. And then I think equitable access would be far easier to achieve. As it currently stands, to create more equitable access with an access program like this is difficult. It requires a good pharmacist, it requires a lot of communications in the province, but I do think it should be pushed, because I think all patients with cryptococcal meningitis should have access to this. So maybe it's just to say that those who do have access and those who want access, they need to communicate and try within the provinces to work out ways of distributing it and getting it to people who need it. Thanks.
John, while you have the floor, there was a question about under 18s. Can you initiate a treatment with the 5FC with under 18s? Over.
As far as I know, you can, yeah. I stand to be corrected. I don't see too many under 18s, but as far as I know, they can access treatment without a problem.
I see Graeme and Eunice nodding in the affirmative, so I think that's... So with respect to registration, the company has sent a dossier to SAHCS, and MSF and Nilesh Governor have sent letters independently to SAHCS, urging them to speed up the process of registration. CHAI is doing something quite similar to get them to register, and as well as trying to work on reducing the cost. But as I think many have said on the call, that the costs will decrease as quantities increase. Back to you, Jackie. Any final thoughts on what you think would work in other provinces that worked for you, noting the differences that John mentioned?
Yeah, no, I think John summarized it very well. I think something that shouldn't stop is the advocacy at all levels about getting access to Cytosine. And then in provinces, perhaps find that central person or provincial lead who will be able to facilitate or help you expand the access program in the province.
Great, thanks. I think we need to draw this to a conclusion so that Graeme can get going with the ambition study. But let me say a few things. So one is that it's clear that 5FC is being used, should be used, is a good product to use. There are challenges at both facility level, provincial level, and of course at national level that we need to tackle. But it's fairly clear that there's appetite from the clinicians to do it. There's a good experiences in, I think, many facilities, and of course at the provincial level in the Western Cape that we can learn from. May I suggest that in order to not put pressure on SAHCS, but let SAHCS know that there's a certain sense of urgency around 5FC, that people on the call, led by the panelists, write to SAHCS, that we collectively write to SAHCS, urging them to fast track the registration. And then we'll do the same with the levers within the Department of Health. So I can see people nodding at that suggestion. So we will draft something and send it to the presenters. And if there are others, the participants on the call that would like to sign up to it, please indicate on the chat that you'd like to sign up as well. And that we will then collectively send a letter to Helen and to me to speed up the process of registration, which will take the burden away from the Section 21s at the individual clinical level. So thank you very much for participating. And I really am an enthusiastic supporter of 5FC as well. And we will certainly from CHAI do everything we can to get the registration going, etc. So with that, let me hand over. Graeme, am I handing over to you?
That's fine. Go ahead. Go ahead.
Okay. Yeah. Thanks very much, Yogan. I'm Graeme Meintjes. I'm an infectious diseases physician at the University of Cape Town, and I'm going to be chairing the next 45 minutes of the webinar. And this portion of the webinar is focused on the Ambition CM trial that is really a landmark trial within cryptococcal meningitis, with exciting findings that will have implications for patient care and clinical guidelines internationally. The findings were recently presented at the International AIDS Conference. And just important to highlight, this is the largest trial that's ever been done in cryptococcal meningitis. It was a multi-center trial involving sites in Uganda, Malawi, Zimbabwe, Botswana, and our site in Cape Town. We're going to have 5 talks in the session, and that will be followed by a panel discussion, and that'll be over the next 45 minutes, as I said. Please, if you have questions as we go along, we're going to save them for the panel discussion section, but please type them in and we can address those in the panel discussion. And before we get going, I just wanted to say a big thank you to all colleagues at DNDi and CHAI for the organisation of this very important webinar today. So our first speaker is Joe Jarvis. Joe is from the London School of Hygiene and Tropical Medicine, has been based in Gaborone and for the last number of years, and was the PI and really the lead and conceived the Ambition trial. And Joe is going to present the headline findings of the trial. So Joe, are you able to share your slides?
Yeah, thanks very much, Graeme, and thank you very much for inviting me to talk on the Ambition study. Let me just share my slides.
Yeah, we're seeing that. That's in full screen. Thanks, Joe.
Great. So hopefully you can see the slides.
Yeah.
Great. Good. So I'm presenting today on behalf of a very large consortium of investigators whose hard work over the last 5 years in particularly challenging circumstances have made this all possible. And there are too many people to thank individually, but I should mention a few people who are here with us today, especially the UCT team with Siphokazi, Kyla and Graeme, and David Lawrence, who is the lead clinician on the trial, who's going to be joining the panel discussion. And also thank the trial participants and the funders, who are the EDCTP, Wellcome Trust, UK MRC, and UK Overseas Development Assistance, and Gilead, who provided the study drug. Sorry, just trying to present the slides. So I think I can skip over the introduction here. I don't think we really need to go through that again. Suffice to say, cryptococcal meningitis remains the leading cause of adult meningitis in most of Southern and East Africa, and mortality remains extremely high. And a key reason for the poor treatment outcomes we see is the fact that we're trying to give long intravenous courses of amphotericin B deoxycholate, a drug that's extremely difficult to administer safely and can cause significant side effects in very resource-constrained healthcare settings. Standard courses of amphotericin B deoxycholate are associated with severe thrombophlebitis, nosocomial sepsis in up to 15% of patients, infusion reactions, anemia, renal impairment, and potassium and magnesium wasting. So there's an urgent need to define safer treatments that are appropriate for low-resource settings. One potential option is to give shorter courses of amphotericin B deoxycholate. And we've already heard about the ACTA trial, which looked at abbreviated 7-day amphotericin B deoxycholate courses in a clinical trial, and showed that this could be safely given, and that 1-week courses of amphotericin B deoxycholate, when given with flucitazine, actually led to lower mortality than conventional 2-week courses, probably due to shorter treatments having equivalent fungicidal activity while avoiding the side effects associated with 14-day treatment courses. But what about liposomal amphotericin B? We know that it's less nephrotoxic, meaning that higher doses can be given safely. It's got excellent tissue penetration and a long tissue half-life, meaning that we should be able to deliver highly effective induction therapy with very short courses. And effective long-lasting therapy with just a single high dose of liposomal amphotericin B has been established in the treatment of another disease, visceral leishmaniasis. In cryptococcal meningitis, its use was previously limited by cost, but if we could shorten the courses and get reduced or preferential pricing, this may be a cost-effective option. So there was a need to define the most effective and the most cost-effective schedules of amphotericin B deoxycholate. We initially performed a phase 2 study using early fungicidal activity or rate of clearance of Cryptococcus from the CSF as our primary endpoint, comparing a single 10 milligram per kilogram dose given on day 1 with fluconazole for 14 days to the standard 3 mg per kg given for 14 days. And also we had a 2-dose arm with a single 10 mg per kg dose at day 1 and 5 mg per kg at day 3, or 3 doses, 10 mg per kg day 1, 5 mg per kg day 3 and day 7. And what this trial showed was that the early fungicidal activity, or the rate of clearance of infection, was actually as good as, or in fact slightly faster with the single dose as it was compared to control. So in terms of our primary outcome in what was another non-inferiority trial, the panel on the right shows the point estimate for the difference in rate of clearance between 1 dose, 2 dose, and 3 doses of the high dose formulation of liposomal amphotericin compared to the control formulation. And first of all, you can see that all 3 short course high dose regimens were non-inferior in terms of rate of clearance to the standard 14-day dosing of liposomal amphotericin B. You can see that, in fact, in all cases, the point estimates suggest that there's slightly faster clearance, if anything, with the high dose regimen compared to standard amphotericin B deoxycholate over 14 days. And you can also see that there's no suggestion of a dose response, in that maximal fungicidal activity appeared to be obtained with that single 10 milligram per kilogram dose, with no additional benefit of adding a further 1 or 2 doses to that. So on the basis of those findings, we sought to evaluate whether this single 10 milligram per kilogram dose of liposomal amphotericin B, when given with an optimized backbone of 14 days of flucitazine plus fluconazole, was non-inferior to the current World Health Organization recommended first-line regimen that had been defined in the ACTA trial. Primary outcome was all-cause mortality at 10 weeks with a non-inferiority margin of 10%. And you will note that in the phase 2 study, we compared liposomal amphotericin B given with fluconazole, but here we're comparing it with a form of triple therapy with fluconazole and flucitazine. And we did this on the basis that in the phase 2 study, we'd shown that the best way to deliver ambisome was as this single high 10 milligram per kilogram dose. But since we'd finished the phase 2 study, the ACTA data had come along showing that 5-FC was an essential component of treatment regimens and the best partner drug for amphotericin B-based regimens. And there was also a slight concern that if we only gave a single dose of ambisome and we gave a long course of 5-FC, we may risk 5-FC monotherapy in the second week of therapy, possibly leading to 5-FC resistance. And also, I think, well, I know that we'd hoped that possibly the triple therapy may be slightly better than dual therapy, and we wanted to try and define the best treatment regimen for HIV-associated cryptococcal meningitis. The phase 3 trial, as Graeme mentioned, was recruited individuals from 8 hospitals across 7 cities in 5 countries in Southern and East Africa. And these data are fairly hot off the press. So we completed the study earlier this year, 844 participants recruited overall, with the last follow-up visit in June of this year. And David Lawrence, who's on the call here, presented the initial headline findings of this at the IAS conference in July. So these are hot off the press results. We still haven't had our publication, but hopefully that will be coming soon. Today, I'll briefly run through the highlighted outcomes. We included adults with a first episode of HIV-associated cryptococcal meningitis. The full criteria are listed here. Late exclusion criteria were put in place to enable rapid enrollment of critically unwell participants while awaiting baseline blood results. Individuals were randomized in a 1-to-1 ratio. After induction therapy, all participants received fluconazole 800 milligrams a day for 8 weeks and 200 milligrams a day thereafter. ART was initiated, reinitiated, or switched 4 to 6 weeks after initiation of antifungal therapy. We screened 1,193 individuals and 844 were enrolled and randomized. After late exclusions, there were 407 participants in each arm, who were included in the intention to treat analyses. And as a great credit to all of the study teams, we didn't lose a single participant to follow up over this entire trial at any of the sites. The two arms were well matched at baseline and represented the general population of patients presenting with cryptococcal meningitis. 60% were male, median age 37 years, and the majority were ART experienced. The proportion of participants with reduced baseline Glasgow Coma score was similar, as were the median baseline CSF fungal counts, which is important as these are the two main adverse prognostic indicators. And here are the primary outcome data of all-cause mortality at 10 weeks. Within the intention to treat analysis, there were 101 deaths in the ambisome arm, giving a mortality risk of 24.8%. There were 117 deaths in the control arm, a mortality risk of 28.7%. The risk difference in the ambisome arm compared to the control arm was minus 3.9%, and the upper bound of the 90% confidence interval, which equates to a one-sided 95% confidence interval for non-inferiority, was 1.2%, well below our pre-specified 10% non-inferiority margin. The results were similar in per-protocol analysis as well. The upper bound of the two-sided 95% confidence interval were also well below the 10% non-inferiority margin in both intention to treat and per-protocol analyses. We found similar results in our adjusted analysis. In the adjusted analysis, the risk difference within the intention to treat population was minus 5.71, and the upper bounds of both the 90 and 95% confidence interval were below zero at minus 1 and minus 0.04, respectively. These primary outcome data are visualized here in a different way. The risk difference of each analysis is shown with the two-sided 90% confidence interval across all analyses, intention to treat per protocol, adjusted and unadjusted. And you can see the upper bound of the confidence intervals well below the pre-specified non-inferiority margin of 10% in all cases. These are the Kaplan-Meier survival curves, with the ambisome arm represented by the dashed blue line and the control arm in the solid red line. Moving on to secondary outcomes, here are mortality at 2, 4, and 16 weeks within the unadjusted intention to treat analysis. And in all instances, again, the upper bound of the 90% confidence intervals well below 10%. This was the case in the per protocol and the adjusted analyses. The early fungicidal activity rate of clearance of cryptococcus from the CSF of both arms was similar. The mean EFA was minus 0.4 in the ambisome arm and minus 0.42 in the control arm, with no statistically significant difference between the two. And finally, the safety data for all individuals who were randomized and received any study drug. Within the first 21 days of randomization, grade 3 or grade 4 events occurred more frequently in the control arm than the ambisome arm, as we would have expected. Grade 3 or 4 anemia was significantly less frequent in the ambisome arm, occurring in 13% of participants compared to 41% in the control arm. The mean decrease in hemoglobin over the first week was 0.3 grams per deciliter in the ambisome arm and 1.9 gram per deciliter in the control arm. 8% of participants in the ambisome arm received a blood transfusion compared to 18% in the control arm. A grade 3 or 4 increase in creatinine was relatively uncommon, developing in 5% of participants in the ambisome arm compared to 6% in the control arm. But there was a difference in the mean increase in creatinine from baseline to day 7, with 20% in the ambisome arm and 49.7% in the control arm. Hypokalemia was also more common in the control arm. Thrombophlebitis requiring antibiotic therapy occurred in 2% of ambisome participants and 7% of control participants. And there was a relatively low frequency of grade 4 neutropenia and thrombocytopenia, speaking to that safety of flucitazine that we've discussed earlier, and very little elevated ALT in both arms. Following the conference presentation, this did generate quite a bit of interest and hopefully is gaining some traction. We can talk about this in the discussion a bit, but it was picked up by several of the main news feeds. MSF put out a press release highlighting the findings and making the point that for this to be applicable, Gilead are going to have to fulfill their promise to scale up access to the drug and ensure that it's affordable. And Gilead themselves did put out a statement stating that they were very pleased with the findings and that they were committing to providing AmBisome at non-profit pricing for the treatment of cryptococcal meningitis in low and middle income countries. So hopefully some progress there. So in conclusion, as Graeme has said, this was the largest cryptococcal meningitis trial conducted to date and has demonstrated that single high-dose AmBisome given with flucytosine and fluconazole was non-inferior to the current WHO recommended standard of care of 7 days of standard amphotericin B plus flucytosine in averting all-cause mortality at 10 weeks. The AmBisome regimen effectively cleared Cryptococcus from the CSF and was associated with a significant reduction in adverse events and offers a practical, easier to administer and better tolerated treatment for HIV-associated cryptococcal meningitis with the potential to reduce the length of hospital admission. We're currently completing a cost-effectiveness analysis of the study, which we hope will provide additional evidence to support the widespread implementation of the regimen. And although we haven't finished that yet, I can tell you that the preliminary findings are in keeping with what we've already seen, that actually using AmBisome doesn't really increase the cost much over and above what we're using at the moment. And in some settings may be fairly cost neutral or even cost saving if we can reduce admission durations. And we now need to make sure that there's access to these treatments so that the benefits of this regimen can be realized. So thank you very much. That's the end of my bit, Graeme. I'll stop sharing the screen.
Thanks so much, Joe, for sharing those important findings with us and really creating the context for the discussion. So we will address questions in the panel discussion section. So we're going to move straight on now to hear a patient perspective from Zikhona Mbota. And, I think just to say that, I think it's critical in this condition to be hearing the experiences and voices of our patients and being responsive to that in terms of the treatments and the management approaches that we have. Zikhona provided consent to be recorded and share her experiences with us. So that's a video recording, and I just want to ask the organizers whether they're able to play that now.
Hospital, I had severe headaches, and it was not just a normal headache because I was taking paracetamol. I was diagnosed with cryptococcal meningitis in 2019. When I came to hospital, I had severe headaches, and it was not just a normal headache because I was taking paracetamol and everything else that you use for headache, but it was not helping. Then I decided to come to hospital because I was at the point whereby I could not see with my eyes and I had a stiff neck. Then I was admitted to hospital. Only then I recognized the next day that I'm in hospital. It was so painful. I was very sick. And all I wanted was to sleep so that I can die. But you are unable to sleep with such pains. The headache was very bad. I've never been in such pain in my entire life. When they started giving me treatment, I took the medication, but my problem was I was vomiting. So I wasn't sure whether the medication getting in my system properly or what, but it took me time to say that the headache has disappeared. But some days were different. I would take the medication and not feel the headache for the whole day. Then when the headaches comes back, I will ask for them to do me a lumbar puncture, which they inject a needle on your back. It was difficult taking the medication 4 times a day because sometimes they would wake you up, make a noise. Maybe if they could have given us the medication twice or once a day, it would have been better. I was very happy to see that the medication is working. I noticed that I no longer have headache and I could widely see people around me. Yeah, then I was not vomiting anymore, so the medication was taken well by my body. It made a huge difference. Having treatment gave my life back. I can now do normal things like a normal person, and I'm so grateful for that. I don't have any fear of getting sick or dying at this point. We know that HIV has no cure, but it can be managed. So taking treatment is the best thing I could ever advise to anyone. Treatment can save your life. If you feel sick, go to hospital, take treatment accordingly as prescribed by the doctor. Then you will be like Zikhona.
Thanks very much, and really uplifting to see Zikhona relating her story, and very grateful to her for doing that for our webinar today. So we will now go on to the next section of the webinar, which is to look at clinical considerations and then a nursing perspective. And these are very brief presentations that are going to be shared by members of our Ambition trial team at the Cape Town site. So first, I'm going to ask Kyla Comins, who worked as a doctor in the trial team at the Cape Town Ambition site, to share her perspectives on clinical considerations of the findings. Kyla, are you able to share your screen?
Yeah, I think so, Graeme. Can you see my slides?
Yeah, if you put it in full screen mode, yeah.
Perfect.
Yeah, that's great, thanks.
Great. Thanks, Graeme, and obviously thank you also to Zikhona, one of our very special patients. So today I wanted to talk just a little bit about the clinical considerations when managing patients with cryptococcal meningitis. I will speak from a doctor perspective. Siphokazi Hlungulu, one of our nursing sisters, will also talk from a nursing perspective. And I think it's just something that, although most of us would have experienced this and would have managed patients with cryptococcal meningitis, sometimes you don't realize how complicated their management actually is until you see it like this. So just by way of background, I think we all know patients with cryptococcal meningitis are ill usually. Most of them present with CD4 counts lower than 100. They're not usually on effective ART. They may be ART naive or non-adherent to their regimens or failing regimens. They're obviously at high risk of other opportunistic infections or HIV-associated malignancies. Of course, there are exceptions to this, but regardless, the mortality, as we've heard, sits at around 40% by 10 weeks. So these patients are treated in hospital. And usually that's because they're sick enough to require admission to hospital, but often it's necessitated by the fact that they receive IV medication for at least 7, if not 14 days. They also require regular blood tests and therapeutic lumbar punctures, and their condition can change very rapidly. So it's important that they are in hospital with close eyes on them. It's really important to clinically assess these patients for signs of raised intracranial pressure and whether or not they need therapeutic lumbar punctures. I'm not going to talk about this specifically because Graeme is going to focus on that a little bit later as well. Of course, you need to look for other opportunistic infections, particularly TB, both pulmonary and extrapulmonary, and it's not uncommon that patients have dual cryptococcal and tuberculous meningitis. These patients are often confused, so they might be uncooperative with medication, especially with Flucitazine being administered 4 times a day, and usually it's 3 to 5 tablets per dose. That can be quite a labor-intensive exercise to get those in. They might be on nasogastric tubes and require pills to be crushed for administration. And then once a day, they also need 6 tablets of fluconazole. And these patients also might not be eating and drinking well. And as we've heard with the toxicity associated with particularly amphotericin B, there's a risk of dehydration in these patients as well. So IV rehydration is really important. It's also very important, and this has been particularly challenging during COVID times, to involve the family early on, counsel around prognosis, and make sure that everybody understands the severity of the disease. In rare cases, these patients are asymptomatic or minimally symptomatic. The patients, for example, who have presented to an ARV clinic, had a diagnostic test and then a CD4 count done, and it's less than 100, and they have a reflex serum CRAG, which is positive, so they get an LP, and the LP is incidentally CRAG positive. So these patients now, who feel quite well, have to be admitted to hospital and start on treatment, and often that doesn't make much sense to them. So it's also really important to explain to them the severity of the condition, the need for admission, to get them on board with that. And also, even in these patients, their clinical condition can deteriorate rapidly. So it's important that we don't naively think that they are well and will stay well. So in terms of treatment, we've heard quite a lot about the updated guidelines over the last couple of years. So the WHO's recommendation and what we use in the Western Cape and what's recommended by the Clinician Society is 7 days of ampho-B with flucitazine, and then 7 days of high-dose fluconazole, which is 1,200 milligrams. Most of the rest of South Africa, as we've heard, uses 14 days of amphotericin B with fluconazole. And in the rest of Africa, as Sarah also mentioned earlier, sometimes fluconazole monotherapy is all that they have access to. It might be because of inaccessibility of the ampho-B itself, or related to the labor intensivity of administering ampho-B, patients needing to be in hospital, a 4-hour-long IV infusion every day, pre and post hydration, etc. So just in terms of the treatments, amphotericin B deoxycholate, as we've talked about, is an IV infusion for 7 or 14 days. The infusion must be given over 4 hours and 5% dextrose. So that's quite labor intensive. It causes quite significant thrombophlebitis in a large proportion of the patients. And as Joe mentioned, that can lead to sepsis. But even if not, it's very painful. The IV lines need to be recited often. And the patients need to have pre and post hydration as well. So good IV access is really important. And the drug is nephrotoxic, causes electrolyte wasting. So you need to supplement the electrolytes, particularly potassium and magnesium as well, while on amphotericin B. It also causes bone marrow suppression and most particularly anemia. And this does seem to be time dependent and usually occur later on in treatment. So the reduction in treatment to 7 days as opposed to 14 does help and reduce the risk of severe anemia and the need for transfusion, but it doesn't eliminate the risk. The liposomal formulation, as we've heard, can be given with a single dose of 10 milligrams per kilogram from the Ambition trial. And it's less toxic than the deoxycholate formulation for the kidneys, bone marrow, and the veins, and obviously only needing to be given once, even if it does result in some thrombophlebitis. You don't need to recite the line. Fluconazole, I think we're all very familiar with, and it's generally quite well tolerated. The high dose is 6 tablets or capsules every day of the 200 milligram formulation. There was a time last year where at Kyla Hospital, we only had the 50 milligram formulation. So those patients were receiving huge numbers of tablets, but generally it's the 200 milligrams that are available. It can be hepatotoxic, but it's not very common. And usually these patients are also on Bactrim. They might also be on TB treatment or INH prophylaxis. So if these patients do develop a drug-induced liver injury, it's more likely one of the other drugs that's causing it, and those should be stopped first and fluconazole continued as far as clinically possible. Fluconazole monotherapy can result in resistance, and so it's definitely not preferred. And because it's metabolized by the kidneys, the dose needs to be adjusted in renal impairment, which, as we know, is quite common, particularly in these patients who are also receiving amphotericin. And then 5-FC, as we've talked about as well, is a weight-based dosing schedule, so the number of tablets varies by patient, but it's usually quite a lot of tablets over the course of 24 hours.
The 6-hourly dosing is challenging. The 10 p.m. and 4 a.m. doses, which are often, they're over a night shift in the hospital. So sometimes there's issues with nursing staff who aren't familiar with the drug or who maybe preferentially work nights and haven't been around in training sessions during the day. Patients are often asleep. So if patients go home while still on Flucitazine, then they often forget these doses. It can cause quite severe nausea, and obviously the meningitis itself and the raised intracranial pressure do that too. So it's sometimes a bit difficult to tease out which it is, but we've found that really only ondansetron works. Mixclopramide and Stemetil don't do very much, but of course, if that's all you have, it's still better than nothing. And it also does cause bone marrow toxicity, but as we heard earlier as well, it's much less common than kind of in theory reported, particularly if it's only given for 7 days. Often you do an FBC at baseline and another one on day 7, and by the time you see the neutropenia or thrombocytopenia, the drug is stopped anyway. But it can sometimes necessitate dose adjustments if it's really severe. And again, it's metabolized by the kidney. So in patients with renal impairment, it needs to be dose adjusted. An important thing to also remember is the other medications that these patients are likely to be on. So most of them would be on Bactrim. Some might be on TB treatment or INH prophylaxis. The other thing is, and of particular significance, is the antiretroviral therapy. Of course, if a patient's ART naive at presentation, it's pretty straightforward. You just delay the initiation of their ART for 4 to 6 weeks to minimize the risk of cryptococcal meningitis iris. But if they are on treatment, then basically it becomes a little bit tricky. If the patient is reportedly adherent, so if the patient obviously tells you they haven't taken their tablets for more than a month, well, then obviously they're not adherent, they're not suppressed, and you delay their ART. But if the patient reports being adherent, it's important to do a viral load and assess whether the patient is in fact virologically suppressed, because there are two possibilities. One is that they are actually non-adherent, and then providing ART in hospital under hospital administering conditions, you're basically reinitiating ART, and the risk of iris is very high. And then the other possibility is treatment failure if the viral load is high, in which case those patients are not going to benefit from ongoing ART anyway, so it might as well be stopped. So it's only in a really small proportion of patients who are on ART and virologically suppressed who you would continue ART for on admission with cryptococcal meningitis. There was previously a recommendation to switch patients onto no-fever-based regimens due to the risk of renal impairment, but with the shorter courses of amphotericin B, that's not necessary. If patients are on effective TDF-based ART, then we can continue. But as I say, it's really the minority of patients who are actually on effective ART at the point of diagnosis with cryptococcal meningitis. And in most situations, we should avoid steroids. There are some rare exceptions, and of course, patients with concomitant TB meningitis present particular challenges in that respect. I mean, it's really important to consider the other non-pharmacological treatments as well. As I said, Graeme will talk about raised intracranial pressure management with therapeutic lumbar puncture, but it's also really important to involve all your allied health. These patients are often bedridden for at least a proportion of their hospital admission. They need physiotherapy and occupational therapy. Sometimes they have particular encephalopathies that result in nerve palsies, stroke, and they actually need specific rehab and physiotherapy for those things. Speech therapy is really important. We usually get the dietitians involved as well. And often a social worker or some kind of social intervention is also needed because of the circumstances to which these patients get discharged. And then there are some other important things that need to be assessed, sometimes during the acute admission, but also later on during follow-up, like visual acuity, which is often impaired, hearing testing, and also additional cognitive assessments. A lot of the patients actually have mild cognitive fallout following their meningitis, which might not be appreciable by the clinician, but if you speak to their families, they report that the patient isn't quite what they were before. And so it's important to get an idea of what that is and involve occupational therapists if necessary. And then just in terms of monitoring, of course, you're going to tailor this to the regimen that the patient's on, but it's really important to just get some baseline values for the ALT, a full blood count, a urea and creatinine, which in our context includes the potassium, but not the magnesium. So you need to add the magnesium. And then monitor these regularly while the patient is on treatment. If they're on amphotericin B, we should be doing a UNE every 2 to 3 days. If they're on flucitazine, we should do an FBC after a week, and the same with patients on ampho B. And we should routinely supplement potassium and magnesium. If patients' renal impairment, or if patients develop renal impairment, then we should increase fluid rehydration, increase potassium and magnesium supplementation if necessary, and remember to adjust the fluconazole and flucitazine doses. And obviously consider transfusion in patients whose HB drops below 8, which is usually more common in patients on a 2-week amphotericin B regimen. 5-FC, as mentioned, can cause thrombocytopenia or neutropenia. It's usually not necessary to dose adjust. The only challenge is if the patients are requiring therapeutic lumbar puncture, that lumbar punctures are contraindicated with thrombocytopenia. So it's important then to balance the need for antifungals with the need for therapeutic lumbar puncture. Once the patients are discharged, it's important to continue with follow-up. They need to be in hospital, obviously, for the duration of their IV medications, but after the 7 days or 14 days of amphotericin B, they can be discharged home. And obviously, you want to try and discharge patients early in order to reduce the risks associated with prolonged hospital admissions, but also balance the benefit of being in hospital and the ability to continue with therapeutic lumbar puncture. So, you need to review the patient at least on day 14 if they've already gone home before that, to switch their fluconazole dose from 1,200 milligrams per day to 800 milligrams per day. And then you also need to see them at about 4 to 6 weeks to initiate or switch or restart ART. You need to see them again at week 10 to dose adjust the fluconazole again down to the prophylactic dose of 200. And then obviously your routine antiretroviral care beyond that with fluconazole for at least a year. So obviously that doesn't all have to happen at hospital level outpatients, but the follow-up regimen needs to be specified clearly so that these patients aren't lost to follow up. So just in summary, these patients are really complex and they're ill and they often have comorbidities and are at high risk for mortality. And even though that then necessitates urgent treatment, the treatment is also toxic and challenging to administer. So just to be aware of the fact that guidelines do differ by region and availability, hopefully very soon, flucitazine will be widely available and the shorter amphotericin B course can be widely implemented. But regardless of what the first 14 days look like, the treatment remains the same beyond that for all patients. It's important, obviously, to manage the HIV appropriately and to involve the allied health services and patients' relatives early on in terms of improving the prognosis for these patients after discharge. So, as mentioned, you're welcome to add any questions into the chat box. We'll take those during our panel discussion a little bit later. But Graeme's going to speak now a little bit more into the detail of the need for therapeutic lumbar punctures.
Thanks very much, Kyla, for that comprehensive overview. I wonder if, in the interest of time, we could just go directly to Siphokazi, and then we'll see if there's time for the discussion of the lumbar puncture. So just to introduce Siphokazi, Siphokazi Hlungulu was the study coordinator for the Ambition trial at our site in Cape Town, and is a nursing sister and is going to speak to the nursing perspectives on the management of cryptococcal meningitis. So over to you, Siphokazi. Thank you very much.
Good morning. Thank you so much, Prof. Prof said, my name is Siphokazi. I'm a registered nurse, and I was a study coordinator for Ambition trials. Dr. Kyla, I will wait for you for the slides. Thank you. Thank you so much. I'll be talking more about the nursing care of the patient with cryptococcal meningitis. As you all heard, that these patients are very sick and they really need proper attention, especially from the nurses. because as they come in, they will be diagnosed with cryptococcal meningitis, and they will be the treatment will be prescribed, which is going to be IVs, that is ample, and that is going to be for obvious. There's KCL that needs to be given prior giving the to the patient, and they're also going to be on oral meds. Also, these patients, they come in like very confused. Some of the patients, they come in very confused, and even with their swallowing, we would need to insert the NGT tubes, and because some of them, they are like very unconscious, they will need to be on the nappies, and they will need also like special cares, because some of them, they couldn't tend themselves. They come in like confused, like I said. So you need to be like, give them like a close monitoring, because as you put on like the IVs, the patient will pull up the drip because like they are confused. So yes. Also, when you are taking care of a patient with cryptococcal meningitis, as Dr. Kyla was saying, there's high mortality. So it's also emotional challenging, because one day you are here, the patient is looking much better, and then when you come the next day, the patient has died. So yes, we need to take that into consideration. Also, the signs to look for when you are nursing the patient with cryptococcal meningitis, because with them, it's not only going to be the situation of giving the medication as prescribed by the doctor. You need to also look for the signs of raising renal pressure, because 1 minute the patients are well, like I said, and the next minute this patient would need like a LP, like just now. So you need to be like monitoring them as you are giving the medication. Look for your severe headaches, like the patient, they will have maybe seizures sometimes, and then they are confused, and that's severe nausea and vomiting. And Dr. Kyla said, we were lucky in our trial to have ondansetron, because sometimes the maxolone and the stemetrol, they don't like work as quickly as one would like. But then we had help of ondansetron that time. Yes, with the medication, the patient will be on IVs, and then you need to give the KCL prior giving the AMPHO for this patient. So it's good 7 days. And as I said, the patients are confused. So you would need to insert the drip. To insert the drip maybe even twice, like in 1 day or every day. Because after giving the AMPHO, giving the KCL is going to be AMPHO, and then after the AMPHO, you would give a flush, which is Novaxanide. But then AMPHO also causes phlebitis, so that is why you need to also observe the lines, because you might change them like as frequently. Yes, and with these patients, sometimes as you are giving the AMPHO, that is why they also like it's true that they need like close monitoring. As you are giving the AMPHO, patient might develop rises. So also what helps is to decrease the rate of you giving the AMPHO, and also the 2 Panados you would give when you are giving the AMPHO. So also that helps. With the medication, there's also fluconazole. Sometimes it's always like there will be Bactrim that we would give. So if you look at the pill burden and the patient is unable to swallow it as NGT, so you must crush all of that medication and give via the NGT. So yes, in giving the Flucitazine, what we did was the staff training, like prior, like coming even to hospitals. It was a bit of like challenging, because the shifts are changing in hospitals. 1 minute we are training this shift, and the other minute we are training the other shift. Also, what was the challenge with Flucitazine? Because it's given to ID, in most cases at night, it's like agent staff whom are not trained, because we didn't really get a chance to see them because they are booked according to the nurse's availability. We might train this one today, and then tomorrow other one comes, and that one is not trained. And in giving medication for this patient, it's not only going to be an issue of giving the medication. It's the nurse doctor relationship is advised because of the dose adjustments. So one must really check, and the doctors, when they change the medication, they must communicate with the nurse, because not every time like the nurse will check. But if the doctor like has indicated that, look, I'm changing the dose of this patient, now it's not going to be QID giving the Flucitazine, it's only maybe going to be PT, that needs to be communicated well. As I've mentioned earlier on, that the pill burden is very high for this patient. If you look at the number of medication that they are giving, because they might also be on TB medication. There's also maybe going to be Bactrim. There's Bactrim, and then there's maybe going to be Maxolone if the patient is having nausea and vomiting. There's supplements, Slow K and Slow K that we're giving, and maybe the patient is also on ARVs. So in overall, when you're looking after the patient with cryptococcal meningitis, you must just know that you are looking after a very sick patient that needs a very close monitoring. Thank you.
Thanks very much, Siphokazi, for sharing your experiences and challenges in this condition with us. So I had intended to give a talk, but we are running out of time, and I do want to have time for our panel discussion. So I'm not going to show the slides. I'm just going to share what my take-home message was with the audience, which just to focus on the issue of raised intracranial pressure, which manifests with headaches, depressed level of consciousness, ophthalmoplegias, and visual disturbance in patients with cryptococcal meningitis. Obviously, when patients present with those signs and symptoms, that the management is therapeutic lumbar punctures to measure the opening pressure and relieve the raised intracranial pressure with the taking of 10 to 30 mils of CSF. And that is often required to be done daily in patients to relieve symptoms. The therapeutic lumbar punctures have been shown to reduce mortality, they reduce neurological morbidity and potentially reduce the risk of blindness, and certainly relieve symptoms, as we heard from Zikhona in the video. The reason why I wanted to bring this up is the focus, based on the findings of the Ambition trial, has been on the drug management of cryptococcal meningitis. But I really want to emphasize to clinicians that the management of cryptococcal meningitis has to be seen comprehensively. It's not just about the drug management. The other aspects are key, and we've heard about some of those from Siphokazi and Kyla. But a critical component of the management is assessing patients with raised intracranial pressure and doing therapeutic lumbar punctures, sometimes daily, to manage that. And the other reason for that, for bringing this up, is one of the temptations from the findings of the Ambition trial is to say that it only involves a single intravenous dose of amphotericin B, and there might be a potential to discharge from patients from hospital earlier. And the risk of that is that patients might then have suboptimal management of their raised intracranial pressure and not get the therapeutic lumbar punctures that are required. Sometimes patients only need their first therapeutic lumbar puncture a few days into admission. So if patients are going to be discharged, one must make sure that they don't have symptoms of raised intracranial pressure if they're going to be discharged early, and have a plan for them to come back to hospital for a therapeutic lumbar puncture if they do develop symptoms. And obviously, if they live far away, one should really carefully consider whether they should remain in hospital for observation for the development of raised intracranial pressure for that week. So that's just to really emphasize that we don't want these findings to lead to premature discharge from hospital and suboptimal management of raised intracranial pressure. That's the kind of take-home message from the talk that I was going to give, and I think that summarizes the key points that I wanted to make. I want to move on to the panel discussion now, and you've been introduced to all of the panelists apart from David Lawrence, and David was the lead clinician on the Ambition trial and really supported all of the sites across the trial in 5 African countries, and presented the findings at the IAS. And I want to ask David the first question, just to ask, you've obviously conducted the trial now, there are the findings out there. What do you think the challenges are in terms of implementing them and access more broadly in Africa?
Thanks, Graeme, for the question and also for the invitation to speak at the panel. I think first and foremost, the first big challenge really is going to be around access to liposomal amphotericin, to ambisome. So at present, it's registered in very few countries in Southern and Eastern Africa, and where it is registered, it's extremely expensive. So I think we did procure a bit of ambisome locally during the trial, and if I'm not mistaken, it cost roughly 2,700 rand per vial, which I'd take to be about $186 US. And that makes this regimen quite prohibitively expensive, as you can imagine. Now, the real challenge going forward is the fact that Gilead have previously committed, as Prof. Jarvis discussed when presenting the results, to an expanded access program to ambisome for HIV-associated cryptococcal meningitis at a cost price of $16.25, which is, less than 10% of the cost, and it would be available in South Africa currently. And really, the need is for this drug to be registered and available at that cost across countries with a high incidence of cryptococcal meningitis. I think that's going to be the main factor. The second, of course, is also the access to the 5FC itself, which we've had quite a lot of discussion about already today, so I won't go over that, but just to emphasize, of course, the importance of the access to the 5FC. So I think those are the two main challenges for implementation. In terms of the response to the results and the integration of these findings into guidelines, of course, that's something that needs to happen with the peer review of the full results when they're presented, and that's for kind of each individual country to address, and also the World Health Organization too. We're hopeful that all of these committees will look very favorably on the clinical efficacy of this regimen. So we don't hopefully see that as being too much of a barrier to implementation. So really it's going to be around the access to the drugs. And just one final point as well, which Prof. Jarvis touched on, is the cost effectiveness analysis. This is something that we are trying to work on as quickly as we possibly can. Obviously, it's been a bit of a short timeline from the closure of the study to the presentation of the results and where we are now. So our efforts are really on the costing, so that we can also provide a very robust argument for implementation from an economic perspective as well.
Thanks very much for those thoughts, David. If I can move on to the next question, and perhaps, Kyla, if you could address this, just to repeat the point that you made about tenofovir and amphotericin.
Yes, thanks, Graeme. So it used to be recommended that patients who are on tenofovir-based ART at the time that they present with cryptococcal meningitis should be switched to an alternative regimen for the sake of preserving the renal function. And that's obviously related to the risk of renal toxicity with amphotericin B. But with patients now taking usually shorter regimens of amphotericin B and with close monitoring of renal function, the recommendation is that patients should stay on their tenofovir-based regimen if it is an effective regimen. So with the caveat that they are virologically suppressed at the time of presentation, and that renal function can just be monitored. So it's no longer recommended that these patients be switched, especially if the patients are using Flucitazine as well. Changing the patient to, for example, AZT is not going to actually provide any benefit, but is also going to have shared toxicity. So there's no real recommendation to switch them off tenofovir anymore.
Okay, thanks, Kyla. So then, Joe, can I ask you to address the question, has anyone investigated ambisome plus flucitazine versus ambisome versus amphodeoxycholate plus flucitazine for a week, followed by fluconazole as induction therapy?
Yeah, so I think the question is, could we just give a 7-day course of ambisome or a 7-day course of amphotericin B-deoxycholate with flucitazine? Nobody has investigated that. So there have been trials comparing 2 weeks of standard dose ambisome to 2 weeks of amphotericin B-deoxycholate. Those studies didn't really show any, certainly no superiority of ambisome over amphotericin B-deoxycholate in that setting, although as you'd expect, the toxicity was less with the ambisome compared to the deoxycholate. Now, I think what we've shown in our phase 2 study is that you get as good a fungicidal activity with a single 10 milligram per kilogram dose of ambisome as you do with 14 days of ambisome daily dosing. So I'd imagine that if we just gave 7 daily doses compared to the single dose, there's no reason to expect 7 days to be better than 14. So I think the same would apply. So therefore, knowing that our 10 mg per kg dose is as effective as 14 days and by extension as effective as 7 days, and the fact that we're giving, if you gave 3 mg per kg for 7 days, that's 21 milligrams of ambisome. If we give a single 10 mg per kg dose, that's less than half the amount. I can see no reason now, with the ambition results out, why you'd want to give 7 days of standard dosed ambisome over the single dose. So I'd advocate for giving a single dose of ambisome in every setting, really.
Thanks, Joe. And then could I ask Siphokazi, regarding the mixing of ambisome, can you speak to some of the challenges that the nursing staff might have had with that?
Yes, Prof. When it comes to mixing the ambisome, it's quite a lot of files, and you need to make sure that the prescription of the ambisome is the correct amount of files, that be in a good relation with the pharmacy, just to double check, because they will come maybe in 10 vials, and then you need about 4. Because on the ampoule we put on like 10 mils of sterile water, but then on the ambisome we put about 12 mils of sterile water. So it's quite a lot. So we really need to train our nurses, because it's a lot of files that one must mix, and then the mixing and the mixing of the ambisome, and then you need to infiltrate it into the vacuolite. So it's not just mixing and drawing and put it back. So you must actually strain the ambisome. So you need those filters as well when you are mixing the ambisome. So it's very different with amphotericin. So there were a lot of challenges, and in overall, the nurses, they said like it's hard work. If it's gonna be introduced, they really need to go for like training, Prof, because it's not easy to mix ambisome.
And how long did it take to prepare?
It will take you a good hour, Prof. If you are mixing it all by yourself, it will take you a good hour. But luckily enough, in our own ambition, we were 2, and the doctors were trained to how to mix ambisome. So it was like a doctor and the nurse were helping each other.
Yeah.
Yes, Prof.
Okay, so that's a key implementation consideration, is ensuring that people are aware of the time that it takes and get the training. Obviously, it's a single dose, so that's the benefit of having to do it for 7 days or 14 days, that you're spending that time just on a single dose. But thanks for sharing that.
Yes.
And Eunice just raises the
Thank
point.
you, Prof. Thank you.
should the mixing not be taken over by the pharmacist? And that's certainly something that we would need to think about. Obviously, this was being done in a trial setting, but once it's implemented in the service, I think that would be a consideration. We've run over a bit, and I think we've heard from all the panelists, and we've addressed the questions that came through the chat. Just to say thank you very much to all of the speakers and the panelists. I think it's been a really excellent session. We've heard about the findings from the landmark ambition trial. We've heard some of the clinical issues and the complexity of managing patients with cryptococcal meningitis. We've heard from a patient about their experience and had some discussion about these issues. So to wrap up, I'm going to hand over to Carol Ruffell from DNDi Southern Africa, who will make some closing remarks.
Great, thanks, Graeme. And so I'm going to keep it very short, really, just to, on behalf of DNDi and our co-hosts for this session, Chai, thank you to all the presenters and the people behind the scenes who've made this pull together. So Eunice, Graeme and Yogan for moderating, so thank you. And as DNDi, we look forward to continue to contribute to the space, both from an advocacy point of view and then our research and development work on a slow release formulation. And really wish you all a very good conference for the